Good morning, everyone. It's a very, of course, strange time, a strange way of teaching. This is meant to be normally a very interactive talk, but I guess I'll be asking the questions myself and answering them myself as well. This is a very practical, clinical talk. So this is not an evidence-based talk. This is something I'm hoping all of you, whichever grade you are, will be seeing or getting involved at some point. And I'll be really giving some practical tips. And please feel free to send your questions to Reshma. We can answer at the end. So here we go. So I'll be mainly talking about airway emergencies today, and how to manage them, and some tips which I've learned over the years in my own practice. So let's make a start. So this is, a classical scenario. You get called from a neonatal unit or the delivery room. There's a newborn child who, was okay when he started crying, but the minute he stops crying, gets blue. So it's a very typical classical scenario, and there are no prizes for this. So that's a choanal atresia. So just to orientate you, this is looking at the back of the nose, the choanae, using 120-degree telescope, and clearly you can see. So that's the septum, and both the choanae are completely blocked. So this is a bilateral choanal atresia. So just briefly as to what this is essentially a persisting buccal-nasal membrane. Majority of the time, it's a mixed atresia. It's not just the back part of the nose, which is atrectic or narrow. It's generally the whole nose can be narrow. And again, specifically at the back, the pterygoid plates and the vomers, which are also thickened, and there is a membranous element to the obstruction. So from your point of view, you get called as a SHO or a registrar, and by the time you go, hopefully the pediatricians would have already tried to pass the catheter through the nose, and they again hit a obstruction. And while you get called, you've taken some history, and you're already thinking as to what am I going to do. So think ahead. What you guys have, or the advantage you have, is already you should go into the neonatal unit with a nasal endoscope with you. So the other ways to check if there's any airflow is simple stuff. You can get a cold spatula, a spoon, a mirror. So that way you get, is there any airflow or no airflow at all, and through the front of the nostrils. And of course, you can suction out first, and then go in with your nasal endoscope. And clearly, with the nasal endoscope, you can physically go into the nostrils and make a diagnosis. Once you have made a diagnosis that it is actually a choanal atresia, and not just a mucus, which is obstruction, then after that, it's a matter of planning and confirming. And really, the only way to confirm, and also ultimately, if the child has a bilateral choanal atresia who will need surgical intervention, you will need a CT scan. So this is the basic, or the most important investigation for us as ENT surgeons that you should request for. CT of the nose, sinuses. Of course, the relevant things are the CT. Whenever you plan the CT, at least half an hour or so before that, you should get some Otrivin drops in, suction out the nodes, and then only send the child for a scan. So you get a true impression, and that's a typical appearance of the CT scan. You can see most of the nostrils are patent, but in the choanal region, there is a bit of membrane and a bit of the bone which is confirms your diagnosis. Now, once you've requested a CT scan, and the other investigations which the anesthetist will be interested in and should be requested at this stage itself, the bare minimum being an echo and a renal ultrasound. Thinking in terms of charge. So charge is again a very common exam question, so be aware of that. But from investigation point of view, you should get a echo done, because without that the anesthetist will not proceed. And also these kids with the choanal atresia can have kidney issues as well. So get an ultrasound of the kidneys done. So this is a bare minimum investigations you need prior to any surgical procedure. Again, as I said, be aware of the charge. So get a ophthalmology review at some point to rule out any colobomas. And of course, a hearing assessment at some point needs to be done to complete the process, but though that's not urgent or desperate. So once you made your clinical diagnosis, you've confirmed your diagnosis with a CT scan, and that's the point you need to start thinking in terms of definitive management. And all depends on where you are, which hospital you are in. Are you at a district hospital? Are you at a tertiary unit? Are you able to deal with the surgical procedure for this in your center? If not, at that point, you've got to start thinking in terms of referring the child to the tertiary unit. Now, another thing to look after as we started was the airway. So, this is a child, the obstruction is at the level of the nose. So the various ways you can manage the child, simple stuff, little kids manage the oropharyngeal airway very well. You can literally stick in an oropharyngeal airway and tape it, and the child has some where to breathe from. They are obligate nasal breathers, and hence they are struggling. Just taping an oropharyngeal airway is good enough. There's McGovern nipple, or you can literally take a dummy and make a big hole in it and stick it in the mouth. And of course, when it comes to transfer and all that, the child needs to be intubated. But that's a decision you take on an individual patient basis. So once you've confirmed the diagnosis, then it's a matter of surgical treatment. So surgery, again, has evolved over the years. I should say in my boss's days, they used to do it blindly. They literally used to stick a finger at the back of the nose and use a bougie at the front. But now, of course, we have advanced endoscopes and telescopes. So we use a 120-degree telescope, as I mentioned, through the mouth. So the patient is in tonsil position with tonsil mouth gag with a 120-degree telescope through the mouth, looking backwards at the postnasal space. The adenoid would be somewhere here. That's the palate. So it's very disorientating. Those of my registrars who've done these procedures for me, they can understand it's very disorientating to start off. You're looking backwards, but after a while you get used to it. So you're looking, make a confirm diagnosis, that's your septum and completely blocked choanae. You use a urethral dilator, start with a very fine dilator, make a puncture, and it's a matter of gradually dilating using the urethral dilators, and that's ultimately what you achieve on both sides by serial dilatation. You've created reasonable space, and that's the results you've achieved. For the neonates, actually at that stage, this is good enough because even if they have mixed stenosis, which they do, but their bone is very pliable, and just using a dilator at this stage for a neonate is good enough. If you do feel you need to do a bit more, then you can do a bit of drilling. For a neonate, I would only use an aggressive diamond bar and just drill away a bit of the bone. And what you're aiming to achieve is approximately, 3.5, 4 millimeter airway in the choanae. Once you've achieved that, then it's a matter of using some stents in, and ultimately these are standard 3.5 endotracheal tubes cut to size. You get both the sort of sides the endotracheal tubes, making sure that the bevel is towards the lateral wall. And then, of course, once you've got the stents in, they have to be secured, and you use a nylon thread to secure these stents. So that's the back of the nose. And at the front of the nose, you put another little bridge piece, and that's to keep this in position. Mainly what you don't want is any cosmetic problems. So certainly you have to look after the columella. So this columella, this bridge piece is literally to keep these stents apart, so there's no pressure on the columella. And at this stage, you also got to make sure that you've not, your stents rather, are not causing pressure on the alar margins. So that's at the end, you're secure, the stents are secure. The patient goes back to the neonatal unit, and then the parents, of course, get trained to look after them, suction them out. The stents stay in for 6 weeks or so, and then you bring them back 6 weeks later for stent removal. So that's really, in a nutshell, how you diagnose a choanal atresia, the basic investigations, and the treatment for it. And we'll take the questions at the end. So continuing, so my next bit of the talk is on airway assessment. So this is going to be relevant to all of you, not just in the acute setting, but also if you get a referral, if you're seeing a patient in the clinic. So this bit of the talk is also, I'm hoping, relevant to all of you. So, as you know, you get a phone call or a referral, be it from the A&E or pediatricians. And, it depends on which level of trainees referring the patient. And it is actually tricky, even for some senior trainees or medical senior trainees, to differentiate what kind of noises they are hearing. So they'll just say, oh, well, the kid is making some noises. But for you, when you go and see the patient, you, in your own head, have to differentiate, is it a stertor or is it actually a stridor? Stertor, the best way I can, so that you understand, is it like a snoring type noise, or is it more a musical or a sharp type noise, more from, the low part of the airway, the larynx and below? And that's the first thing you've got to differentiate. And this is, of course, you can't do this over the telephone. So you have to physically go and see the patient. And majority of, you'll see the airway assessment that I'll talk about is all about history taking and talking and listening. It's not about, you don't have to actually touch the patient, and 90% of the times you'll be able to get to some kind of a provisional diagnosis. So that's the first thing, to differentiate, is it a stridor or is it a stertor? And again, if it's a stridor, you've got to again concentrate, listen for good maybe a minute or so, check, is it inspiratory, is it biphasic, or is it only expiratory? Because again, these are the kind of questions I will ask when you discuss this patient with me. And because it gives me an idea which level the obstruction is, or the part of the airway which could be causing these issues. So clearly, inspiratory stridor is only during the inspiratory phase, that kind of noises, and of course that's would indicate something at the level above the vocal cord. So either supraglottis or glottis. If it is a biphasic stride, both inspiratory and expiratory noises, then yeah, that would be indicative of something below the vocal cords, generally subglottis, sometimes lower tracheals. And expiratory is more like a wheeze. So, we generally wouldn't get called for that. So investigations, I say, but it's more about assessment. So I think, again, I've divided this into history examination, radiology, and finally, the gold standard, of course, is the endoscopy. So, as I said, 90% of time, you should be able to get to a provisional diagnosis just by history. And again, examination will kind of confirm your provisional diagnosis. So you need to start thinking right at the level of history as to what my provisional diagnosis could be here. So at this stage, normally, of course, I ask you guys, but I'll have to just tell you. So history wise, again, it's the way I teach my registrars and even myself when I take a history. You will not forget if you start from the beginning, whichever level you're seeing the kid, whatever age the child is, be it an acute situation. So start from the beginning, and was the child born on term? Start from then, and you'll never forget. So is it a term baby? Is it a preterm baby? If it's a preterm baby, or even if it's a term baby, the next question I ask them is there a history of intensive care, special care admission or not? That way you don't forget if you follow it serially. And again, if they say, oh yeah, he went to the intensive care unit, and then straight away you ask them, did he need any airway support or breathing tubes and all that. So I think that's really the key questions to start off. And then, of course, you come to the noisy breathing. Noisy breathing, when did it start? Did it start at birth? Did it start a few weeks after? Is it just something off late? And again, like any standard history, onset, progression, are there any things that make it better, anything that make it worse, anything precipitates it? Is it positional? Is it better with sleep, worse with sleep, better with feeds, worse with feeds? Those kind of questions. So aggravating, relieving factors. And the next question you ask if the child is by that time not vocalized or cried is how's the voice or the cry? Is it a normal cry? Is it a hoarse cry? So that again gives you an idea. Is there something going on at the level of the vocal cords or not? And then I move on to other things like suggestive of aspiration. So, are there any coughing, choking spells on foods? Are there any blue episodes? So blue episodes are quite classically would be indicating of tracheomalacia. So after that, move on to the swallowing. Is the swallowing normal? The child breastfed, bottle fed, any choking episodes on swallowing, any feeding difficulties? And then I move on to how's the weight gain, because weight at any age for the child is a very key indicator, because that tells me if the child is thriving well, my worry is really or concerns are gone down, because I know if the kid is thriving well, he must be feeding well, and his airway can't be that bad. Because certainly if the kid is not feeding well and has increased work of respiration because they're struggling to breathe, they will not be gaining weight. So that's again quite a key question. So again, just a summary. So I think the key questions are: what's the age of the child at presentation, gestation, history of intubation, and then don't forget the general medical history, and really 2 or 3 things which we are most interested in kids' airways is what's the situation of the lungs, what's the cardiac status, neurological status. So these are 2, 3 things, and initial um, sort of presentation, as well as you've covered all this, you would have covered 90% of the history that I would like you to think. Then you come to examination. Again, as I said, history in kids' airways, the history and examination are almost happening parallel. When I'm seeing a patient in the clinic, I literally ask the parent to turn the child or face the child towards me. So while I'm talking the history from the parent, you're also examining the child, you're observing the child. So I think there's a lot of these things happen in parallel. And examination, as I said, is actually all or majority of it is about observation. Is it a child who's comfortable breathing normally, or is he really gasping for breath? So, I mean, I'm not saying you've got to start counting the respiratory rate, but it'll give you an idea. Is it a normal breathing, or is the kid tachypnic? Is the kid looking okay? Is it looking pale or blue? And then, of course, you start listening to any excessive voices. Again, it is stridor, it is stertor, what type of stridor, and again, voice, cry. You also at this stage, if you do feel that the kid has continuous or regular noisy breathing, is there an associated excessive accessory muscles of respiration are working, meaning do you see any suprasternal recession? Do you see any tracheal tug? That straightway would indicate the kid is really struggling and this is a significant airway issue. And don't forget the hemangioma. We are not pediatricians. I'm not at all expecting that you should completely bear the child. If you just ask the parent that are there any birthmarks? If the parent says no, then that's fine. If the parent says yes, then at least look at the birthmarks. Is it relevant or is it not relevant to you? But do ask that question at some point, be it in history or examination, that are there any birthmarks? So by this time, with a good history and examination, you should have reached some kind of a provisional diagnosis. And again, depends on the setting. If you get called from a ward or the A&E and somebody's already done or attached the pulse oximeter, so yeah, do look at the pulse oximeter. But I wouldn't be very much reliant on pulse oximeter. For me, looking at the child is much more relevant than the oximetry. And of course, if you're being called from the NICU or PICU, they would have done some blood gases for you already. Radiological investigation, I will say, almost irrelevant. We hardly do, and certainly I wouldn't be requesting for radiological investigations. But yeah, again, if somebody's done it, somebody's done an X-ray of the neck, X-ray of the chest. We used to do barium swallow for vascular rings and all that. It's completely gone out of fashion. Bronchogram, again, it's a secondary investigation. If you're thinking in terms of tracheomalacia, bronchomalacia, but that's again pediatric respiratory territory. Echo, yes, echo is still relevant if I made a diagnosis of tracheomalacia. But these days, if I made a diagnosis of tracheomalacia on an endoscopy, I would straight go to MR angiogram.
Prof, sorry to interrupt. Just can hear something from your microphone. I don't know whether something of it at the moment. Okay, thank you.
So flexible laryngoscopy. Flexible laryngoscopy, yes, all of you have access. So, as you notice, I've come to flexible laryngoscopy quite later on in the day. So History examination is still the key for you to make the diagnosis. So flexoscope, yes, you should do a flexoscope, especially if you, ideally, if you have the pediatric flexoscope. It's a good screening tool. For those of you who worked in the pediatric settings, you know it's not easy to get a good diagnosis on a flexoscope in a child. So hence, I actually tell the trainees, you know, with a child, as most of you know, you'll max get 5-10 seconds view. That's max you're going to get. So the more you do it to start off, you'll get better at it. So I think it's not a bad idea to start doing flexoscopes on all the referral. That way, you just improve your skill techniques. You become more slick at it, and it's a quick in and out. You know, max the child or the parent will be able to hold the child for you will be a minute or so. So certainly, it's a screening tool. It gives you some idea of vocal cords movement. It certainly does not exclude any lower airway pathology. And I mean, this is a literature saying that, you know, 20% of kids who you made a diagnosis of laryngomalacia on flexoscope will have a second pathology. But in my hands or in my series, almost 40% kids who have laryngomalacia, I do find a second pathology, but my practice is, of course, very skewed at the extreme end of the spectrum. Right. Popular exam question, and you should know this anyway. Anesthesia for an upper airway endoscopy is very different to any other anesthetic. And again, those of you who work for me or seen airway endoscopies would know it's more an anesthetic challenge than a surgical challenge to do an airway endoscopy, because the anesthetist has to give you, it's a dynamic assessment of the airway. So the anesthetist has to give you a child who's breathing on their own, self-ventilating, still you are able to literally use your metal endoscope to assess the airway with that breathing child. So it's a very tricky anesthetic plane they need to get the child into before you can do anything. So the key thing that you have to be aware of, and certainly from the exam point of view also, it's a spontaneous respiration technique. All that I've mentioned here happens in the anesthetic room. So the anesthetist would give them some atropine for two reasons: to dry up the secretions and also to reduce the risk of bradycardia. So bradycardia can happen, especially if your endoscope touches the carina. So that's the rationale for atropine. Generally, and to start off, they'll give them a gas, usually sevoflurane, just to sort of more as a measure so that they can get their lines and cannulas in. Once they've done that, they get their accesses, they get monitoring. And I don't interfere much with the anesthetist. There are various ways of doing anesthesia. Generally, what I see is the anesthetist would use gases for very young children, and for slightly older children, they will use intravenous anesthetic and a mixture thereof. So for us, the key thing is the lignocaine spray. So lignocaine spray is one key thing unless the anesthetist has done a good local anesthetic spray, you really cannot do your endoscopy very well. So that's a key thing that happens in the anesthetic room. And then they put in a nasopharyngeal airway, which is what delivers the oxygen and any gases, and of course, full monitoring. And then the child comes in to you. Positioning wise, I position, and I tell my trainees as well, the positioning is quite a key thing. You know, unless the position of the child is correct, you'll keep struggling. Remember, it's a rigid metal rod, and the airway from the lips or the gums to the carina has to be in a straight line. So what I would use is an age appropriate shoulder roll, and I just use some kind of a support to steady the head. It's just normally I use a C-shaped horseshoe or something like that. And once you position the child, then you can go ahead and do your endoscopy. This is a normal endoscopy, as you can see, good views. This is taking a video that's coming out. You're looking at the tracheal rings, nice C-shaped tracheal rings. And as you come up, you look at the subglottis, the vocal cords, and of course the supraglottis. So I have, so this is again how I would, and you should also divide your airway endoscopies. So as you're going in, look at the supraglottis. Supraglottis, again, you're looking at the epiglottis, epiglottic folds. Is there a shortening? Is there a floppiness on the dynamic inspiration? And then once you've done that, you would also then look at the vocal cords, just look at the structure of the vocal cords at this stage, any nodules, any papillomas. And then, of course, subglottis, you initially just have a little look at the subglottis and see any obvious pathologies. And then, of course, the subglottis needs to be sized up at this stage. And then you look at the upper trachea. Again, looking at the tracheal rings, any evidence of tracheomalacias, and then lower trachea and main bronchi. So that's your normal airway endoscopy. But of course, not all airways are normal. So this, from memory, was a child who was about 6 months of age with some noisy breathing. He was intubated, I guess, due to some sleep apnea, and then we got called to see. So you can clearly see that's an nasopharyngeal airway position, that's an NG tube. And so yes, certainly at the top, there's some evidence of laryngomalacia. And at this stage, I really actually don't know what to expect. I knew there was some suggestion of laryngomalacia in the history. So as you're going in, you can see the left vocal cords looks okay, right one looks a bit swollen. And then you start just getting a glimpse of the subglottis, and you just see just literally a 2 millimeter hole. So she's also got a subglottic stenosis going on there. Okay, that's sort of, I should say, upper airway assessment. And I'm going to move on to the airway inflammatory conditions, which at some point you will get to see, or at least get called to give an opinion on. So I'll be touching on Croup, tracheitis, supraglottitis, and retropharyngeal abscesses. So Croup, as you already know, is actually one of the most common causes of sort of noisy breathing following an upper respiratory tract infection in an otherwise healthy child. And majority of the times, I would say almost 60–70% of times, the child with Croup comes to the A&E, gets seen by the A&E, they do assess them, give some treatment, and off they go. So you don't even get involved. If the Croup is not responding, then the pediatrician get involved, and they would do some treatment. And it's only very rarely that as ENT surgeons, you will get called to see a child with Croup clearly, and that happens if the child is not responding or not doing what the pediatrician would expect them to do. So the classical story is it's an otherwise healthy child. It's a young child usually, but can be anything between 3 months to 3 years of age. Gradual onset, starts with the standard cold and starts with following, and the child starts getting barking cough, and then develops a biphasic stridor. Usually more common in boys than girls. Of course, it is much worse in winters. One of Croup, I have to say, majority of the kids get and settles down either with some basic measures, maybe one of oral steroids, and you don't even hear anything more about it. But there are some kids who do get reoccurrent Croups. I mean, one key message that I would like you as ENT trainees to take away from here is, do check if you've been called to assess a child with a Croup, that is the first episode or is this a repeated episode? Because that's something as an ENT trainee you got to pick up on, because pediatricians might not. Certainly if if there's a child who's had more than 3 episodes of Croup, as far as you're concerned, the child needs a formal endoscopy at some point, more sort of electively, to rule out subglottic stenosis. So any more than 3 episodes of Croup, you should be thinking in terms of a formal airway endoscopy when things settle. So again, I'm not suggesting that you should be sending the kid for an X-ray, but if somebody has done an X-ray, that's a classical steeple sign that you see, which shows a very narrow subglottis. So this is just another kid where sometimes you get arm twisted to scope them. So again, spontaneously breathing child, you go in and that's your classical appearance of Croup with very, very swollen, so perfectly looking vocal cords, very, very swollen subglottis. So treatment, standard treatment is a lot of humidification. If the kid is struggling in the A&E or on the ward, then yes, don't hesitate giving adrenaline meds. Yeah, generally 0.5 to 1 ml of 1 in 1,000 adrenaline diluted in 3 to 4 ml of saline and just nebulize them. Again, do not hesitate in giving high dose dex. I mean, I've written here not 0.5 to 1 milligram. I mean, just even if you just remember 1 milligram per kilogram, you'll not go wrong. Oral is as good, so you don't need lines or anything, so just give oral dex. And the anesthetists don't even hesitate going up to almost 2.5 milligram per kilogram, so don't hesitate giving dex. So, but you got to understand for yourself also, dex will not work instantly. Dex is going to take an hour to work maybe. So it's the adrenaline which will work instantly. So you've got to give, it's not, oh, let me give one and let me try one, see what happens. You've got to give both. So adrenaline will essentially, settle this swelling topically, so to say. And that buys you some time. By the time the dex would have worked in maybe, half an hour, 40 minutes. And of course, you've got to check what's the status of the oxygen saturations, CO2, and you've got to start thinking, has the child just settled down with one adrenaline neb? But if the child is needing adrenaline more than once an hour, you've got to start thinking, or the anesthetist will start thinking in terms of intubation. And again, usually if you're called at this stage, you got to start thinking, what am I going to do? So most of you who work with me know, there are charts available. If not, ask the anesthetist what size endotracheal tube will be appropriate for this child. But remember, this is a kid with Croup, so don't even think of going with a normal endotracheal tube size. So go with the 0.5 millimeters smaller. If nothing else, this is one slide you need to pay attention. And I bet Liam can vouch for this. He was in the situation very recently, a few weeks ago, working with a very senior pediatric anesthetist, Croup type scenario. And the ENT surgeon are asked to be standby. So And of course, the anesthetist will try twice to intubate, and that's what happened. They couldn't, and off you go. They just hand the child over to you, and you're thinking, what do I do now? So I think this is what I would suggest. This is one technique which has saved the day for me also many a times, not in group situations, but generally otherwise. And I would highly recommend that this is one thing you should be prepared for in any area scenario you get called. And it's simple stuff, a small 2.5, 2.7 knot degree telescope, and 3.5 endotracheal tube, and sort of cut it to size and make sure it fits in there, and really make sure it slides over nicely. And once you get handed over the child, you again use, I normally would just use an anesthetic laryngoscope, and everything is on the screen. You can see, because you're more used to working with screens, you've got a rigid scope in your hand. Not just you, the anesthetist can see where you are, and everyone knows what's going on. You get into the airway and just literally slide the tube through, and the situation is diffused. So that's the key message I have to give you in this talk. And yes, rest of the talk, you people who have to leave can leave. I think this is one key message in this talk. Recently I was in a situation where, again, Ellie will remember this kid, and Matt too, the kid with a huge molecular cyst in the intensive care unit. And again, comes to theater, anesthetist has a look, doesn't say anything, hands the kid to me. So again, with the endoscope, and yeah, this is a great view. If you see this, yeah, that's great. It's actually not difficult. So in that kid, all I could see was just one hint of one arytenoid. That's all I had view. But I knew if there was a arytenoid there in front of it, there will be airway. So this really helps, this technique, in many situations. Okay, so that's Croup done. Move on to tracheitis. Very rare, but be aware. Be aware, I say, because this is generally an older child. If you get referred a 6-year-old or a 7-year-old with a croup, you think, why should a 7-year-old have a croup? So be aware, this is an older age group kid who's very toxic. History would be quite similar to croup, but the child is quite unwell and toxic, because this is usually a staph related, usually a bacterial illness. And again, you've given your adrenaline and this and the other, and the child is not responding. And again, this is usually associated with pneumonia. So be aware. Again, I'm not at all suggesting that you should be sending these kids for an X-ray, but again, if somebody has done an X-ray, there will be a diffuse haziness where the airway or air column should be, because it's a pseudomembrane. So if you just imagine the tracheal mucosa has just literally sloughed off. So that's the difference between croup and tracheitis. Management, again, no different than croup, but these kids are much sicker as compared to croup, and generally will end up needing an intubation. Of course, antibiotics focused at staph. How are we doing for time? Okay. Right, so another 5-10 minutes. Supraglottitis. Luckily, we don't see much supraglottitis in children in this country, especially since the Haemophilus vaccine was introduced, because the most common culprit here in kids is Haemophilus influenzae. And again, starts off with just a standard cold and really rapid progression. But the key difference between croup and epiglottitis is, in addition to stridor, the kid is drooling. The kid is really not able to swallow at all. And really struggling, head extension, jaw thrust, open mouth, this kind of position. Again, not at all suggesting you should be sending the child for an X-ray, but if somebody has, then yeah, there's that big sort of swollen thumb type epiglottis. And if it reaches a stage that you do end up intubating the kid, so same principle, railroad your endotracheal tube on the telescope, and that's the kind of difference, just for illustration purposes. So it's just the epiglottis which is very, very swollen. Once you're through or reach the level of the vocal cords, the situation is diffuse. So, especially if the kid is sick, don't waste your time with investigations. Give your standard oxygen, adrenaline text. Involve the anesthetist, involve the ICU team. This kid is going to need intubation, but don't attempt heroics in the A&E setting. Take these kids to the theater settings where the anesthetists are comfortable, you're comfortable, and of course you need the senior most or the most experienced pediatric anesthetist that is available. And again, certainly the anesthetist would know, but you don't want to be paralyzing these kids and make the situation worse for yourself. So yeah, spontaneously respiration and all that I've already told you. And of course, in any of these scenarios, have your tracheostomy trays available and tracheostomy tubes available. But I have to say, majority, 99% of times, you will manage with the endoscopes. Of course, treat the child or get the pediatricians involved, blood cultures, cultures from the epiglottis, third generation cephataxime, and extubate when ready. And remember, this is a child. It's not just the supraglottitis that you're focusing on. So hence, involve the pediatricians. Don't miss meningitis and pneumonias. I'd like to briefly touch on retropharyngeal abscess. Pretty rare, or I should say the severe ones are pretty rare. Reshma was involved with one recently, and this is one I was involved maybe 5-6 years ago. So even a tertiary unit at Royal London, we don't see any more than one case in maybe 3 to 4 years. The extreme end I'm talking. Yeah, of course, the minor ones you don't even know. We just get some antibiotics and get better. You never hear about them. So the tricky thing with the retropharyngeal abscesses is there isn't a classical history. And that's a tricky bit. So the standard story is, it's a 3-year-old child who comes with difficulty swallowing. Pediatricians manage it, thinking it's tonsillitis, pharyngitis. It's only after a while they start getting you involved. Either the child is having some intermittent desaturations or now struggling to swallow. So be aware, if you look at the throat and the tonsils look fine, look beyond. And that's what I teach my registrars. So don't hesitate to flexiscope. Don't hesitate to ask for a scan. And this is a kid which I was involved, is quite similar to what you were involved, Reshma. And huge, by the time the kid is really struggling, you can see a huge retropharyngeal abscess. And yes, by this time, kid has been on antibiotic for 7 to 10 days, but the abscess needs to be trained. So as you can see, multiloculated abscess on this MRI scan. So again, this is more an airway problem rather than an abscess problem. And again, in this situation also, it's more an anesthetic challenge rather than a surgical challenge. Once a tube has gone in, it's not a difficult operation at all to deal with. But again, the experienced anesthetist will know how to deal with it. it's a very cautious laryngoscopy and intubation. And in this pictures, you see the child is in tonsil position, and there's a big sort of bulge in front of you. Um, I wouldn't straight away put a knife in any bulge. So the first thing you do is stick in a wide bore needle. One, to confirm your diagnosis, and second, of course, to get some pus for culture. And you can see already with the needle itself, you get about 5-7 ml of pus. Once you've confirmed your diagnosis, of course, you have to stick in a knife. You incise, and I think. So again, this is, by the time you get involved, it's a very thick walled, you can see already we've gone through a few layers, and only after multiple layers you actually hit the abscess cavity. And the pus just keeps coming out, and really loads and loads of pus still comes out. And once you've done all that, you got to open up all the septations. And the tricky bit then is, what do you do next? In any other abscess, you would stick in a drain. But in these kind of kids, you can't stick in a drain in the throat. So yeah, open to the best of your abilities. And the next bit is either, so what I did for this kid was to bring them back to theater in 1 week time to check that there's no recollection. The other option is you can rescan them, and both are reasonable options, because for a little child like this one that I dealt with, MRI scan will need a general anesthetic. So hence I decided it's going to need a general anesthetic. I'll take him back to theater. So if he needs training, I just do it. So this is just a summary. So young child, common things: croup; slightly older child, tracheitis; retropharyngeal abscess, pretty rare, but be aware and have a think about it. And again, luckily in children, supraglottitis is also very rare. Literally last 5 minutes, foreign body bronchus. Again, as I said before, history. So I actually only rely, or I make my decisions mainly on the basis of history here. So the classical history is an otherwise healthy kid, sudden, witnessed or non-witnessed, sudden bout of violent cough, which over time might settle down. So that's a classical history. And by the time, you get to see the child, the kid might be completely fine. But similarly, you will do your standard airway questions and airway examination. We as ENT surgeons are quite bad. We don't carry stethoscopes, but don't forget auscultation. So do auscultate. You might get some signs. You might hear a wheeze or something, or reduce air entry. Yes, in this scenario, certainly I would ask for a X-ray of the chest, if not but done already, and then start thinking in terms of if the history is classical, you are suspecting a foreign body bronchus. Even if the kid is stable, don't sit on it. Certainly don't send the kid home. Talk to somebody. And yes, if you're not in a tertiary center, talk to your tertiary pediatric unit, because I'd rather have a negative scope than you miss a foreign body and then I'm dealing a week later with a very sick child. So this is just a bronchoscopy showing a peanut, a small size peanut in the right main bronchus. And you can see classically, there's enough space around this. So the kid will be breathing reasonably, and you might have a wheeze, you might have no signs. And then, of course, we use optical forceps to retrieve the foreign body under vision. And once you've done a bronchoscopy, especially for any foreign body, don't feel very excited to have removed a foreign body, because you just don't know, is this just one foreign body or there are more foreign bodies behind it. So always do a check bronchoscopy in the same kid, and you can see, where the peanut was, how inflamed this. And this is not even an old foreign body. So just imagine, and don't forget, of course, the other side bronchus. This is just another case, and these are more tricky ones. This is a tracheal foreign body. This is a large seed which is literally flopping in and out, or literally sitting in the carina. So again, you have to decide when to do the bronchoscopy depending on your index of suspicion. So again, my main tips is the history. History is the key thing here, and observation. Observe the child and teamwork. You got to have team. You cannot, I can't turn up to a small district hospital and do these kind of cases. So I need my setup, I need my nurses, I need the anesthetist. Anesthetist, or a good anesthetist, is the key to a good, for you to get a good result. And to be honest with you, I've done more than 1,000 endoscopies, but I still get surprises. So expect surprises. And once you've got a good team, airway endoscopy, you can really be chilled out. But the team is very, very important. And that's that. Reshma, before questions, I just like to say thanks to Stores, who's sponsoring all this for us. And this is just a bronchoscopy guide which Stores has published. There are a lot of YouTube videos also for assembling the bronchoscopes. Stores has also given me this. You can take a picture, you can scan, it'll take you to the bronchoscope assembly thing. And this is also leave it on for contact for the Stores people if you wanted any more sort of bronchoscopy help, or they provide dummies, training kits. So thanks a lot to Stores for this. That's it, Reshma. Questions?
Thank you so much, Prof, for that fantastic talk. I think it's perfect for the registrars, and lots of practical advice that anyone can draw on in an emergency. So we'll start with the questions. We've got one. The first question is, how does unilateral choanal atresia present? And does it tend to be in neonates as well? Does it present in neonates?
Okay, so thinking back, so majority of the times, unilateral choanal atresia actually don't present at birth or in a neonatal period, because if the other nostril is perfect, the child will cope. So really, it's an index of suspicion. So generally, if a parent says that this kid or my kid has this sort of yellowish discharge only from one nostril all the time, so that's a classical presentation, and they go to the GP. And again, if it's a sensible GP, you're thinking unilateral discharge. And then again, unilateral discharge, is it a foreign body? But then if it's a unilateral discharge right from birth, that's really the first presenting symptom. Many a times, and I certainly can remember two, one of them recently, Reshma, you also saw, that I picked up while doing an adenoids. You're doing an adenoid, you think, the catheter is not going on one side, you think, okay, you go on to the other side. And then you, when you look with a mirror, you pick up. So there have been few which you'll pick up while you do your adenoids. Having said that, also had picked up unilateral choanal atresias in adults sometimes while you're doing a septoplasty, something that can be a completely incidental finding also.
Okay, thank you. When you put in your stents, and you said you keep them in for 6 weeks or so, do you give any antibiotics, either topically or systemically?
The short answer is no. So what I do advise, and initially for a few days, the child stays with us on the unit, the registrars go and see. The main thing that the registrar or whoever is seeing the child is that the stents are not rubbing against the ala or the columella. And simple stuff, paraffin, Vaseline, you just apply a bit of Vaseline or paraffin around the stents or the ala over the next 6 weeks period, and that does the job. So no antibiotics are not needed.
Okay, thank you. Similarly, any experience of management of nasal pyriform aperture stenosis?
Yeah, so pyriform aperture stenosis are much more difficult to manage. The management is similar. They don't do very well, let's put it that way. So yes, if it's many a time, like I said, when you get called to the neonatal unit, and that's where you come in when you go with an endoscope. And I certainly remember 1 or 2 cases that I got involved with. It's more a pyriform aperture stenosis rather than actually a choanal atresia. So hence your endoscope is important, or a diagnosis, the scan is important. So if you're able to manage conservatively, meaning simple stuff, salt water drops and some betnasoltride drops, and wait for the child to grow. So that's the conservative of medical management. If you're able to manage, and again, certainly remember 1 or 2 kids that have simply managed just by conservative treatment or a little bit of help with decongestant or steroids, and just wait for them to grow. Remember, as the child is growing, the nose is growing, and you will be okay. What you're really trying to avoid is crusting. So if the medical management works, that's really the best treatment. If it doesn't work, then yes, you've got to go in and drill it out. It's a sublabial approach, and you just have to drill the area of that narrowing with a pyriform. But again, I have to say the results are not great because it will lead to scarring and this and the other. So that's really the last resort. I wouldn't straight away jump and go with the drill.
Okay. Have you managed choanal atresia repair without stent insertion?
Okay, very good question. So there's a very different practice, I should say, in UK and the continent. In Europe, and I should call it Europe now, we're out of the Europe. So in the continent, especially France, they don't stent. And that's totally fine. I'm talking bilaterals. So unilaterals, I don't stent anyway. Bilaterals, I'm stenting because the kid is an obligate nasal breather. Okay. So stent or no stent, that's totally an individual choice. So in the continent, they don't stent. So stents have their downsides as well. As I said, more cosmetic issues, especially alar or columnar scarring it can cause. So it's not, oh, we must stent. Okay.
Is there a role for topical mitomycin C in choanal atresia?
Again, it's a short answer is I don't use it. And majority of the people, it was in vogue, but it's again gone out of fashion. It's not really needed. Yes, of course, it reduces the scarring and all that. But it also, comes with its own risks because it's very aggressive treatment. So, yeah, when the kids who don't do well are kids who actually got charged. They are the worst case scenarios for choanal atresia. Having said that, charged kids just don't do very well with choanal atresia, whatever you do. And that's really my experience, because it's not just, if it's just the choana, that's the good one, you can give them good results. But charged kids have a very narrow nose. It's not just the choana, the whole nostril is narrow. And you stretch them, you dilate them, you stent them, and within a month or so, they're back to square one. So they don't do very well.
Okay. Moving on from choanal atresia, it's about your airway cases. Might be a question more for the anaesthetist, but do you give maintenance through IV propofol or continue with inhalation sevoflurane fluorine?
I kind of answered that question, but as I said, I don't get involved with the anesthetic techniques, but I can tell you what I see. But every anesthetist has a very different. So I work with anesthetists who will do everything completely inhalation. They don't use intravenous at all. On the other end, I work with anesthetists who do a total intravenous anesthetic and don't use gases at all. And then there's an in-between who will do a bit of gas and then top up with propofol. So that's purely for the anesthetist individual preference. And I don't really, it's like the anesthetist telling me, oh, that's the way you should do your endoscopy. So I don't tell them what to do. But yeah, that's what I've observed. Everyone has a different technique from a purely gases to purely intravenous and somewhere in the middle. That's for them.
Okay. Another question, what is the differentiating aspect of the history for foreign body inhalation, which mandates an MLB? So,
as far as I'm concerned, if it's, as I said, witnessed or unwitnessed, healthy child, sudden onset, violent bout of coughing, which continues for a while, and then it settles down. So that's a classical history. And, if you just imagine yourself, if you're having a drink of water, a drop goes the wrong way, what kind of cough you get. That's the kind of cough I'm talking about. If it's a sensible parent, decent history, as I said to you before, I have my registrars know, I have a very low threshold of scoping. I'd rather scope and reassure myself and the parent than sit on it and then be in a situation later on. So yeah, sudden onset bout of coughing in a normal child.
The question about if a child has been brought in with a history of foreign body in the nose, and then you've scoped them or you've examined them, you can't find anything, then when do you worry about whether it has been inhaled?
I don't. Yeah, as I said, it's a history. I am, Reshma, you've been doing it for a while and I've been doing it for a while. I have yet to see or hear, or for that matter, to see a publication where a nasal foreign body has been inhaled. So I actually don't worry too much about a nasal foreign body. I'm not saying sit on it. It needs to be dealt with. Yes, if the nasal foreign body was there when you saw them or somebody saw them, and when you physically take them to theater, it's not there, it's quite likely that the child has swallowed it. Okay. Again, there will be that history, you see. And the foreign body could not have gone into the airway without that violent cough. Of course, if there is that history of violent cough, then yes, I wouldn't hesitate, scoping them. Mm-hmm. But yeah, for me, it's a history.
As long as you safety net, I guess, as well. Moving on to the children with retropharyngeal abscesses, how do you decide whether they should remain intubated or extubated post-op?
I would extubate them. That particular kid that you saw, it again depends on how sick the kid is. By the time we get involved with these kids, on an average, they've had at least 7 to 10 days of antibiotics. So they're not that sick. It's just they're struggling to swallow and, saturation is dropping and all that. So as far as you have drained the abscess and the kid is otherwise okay, I have no hesitation extubating the kid at all, literally on the table. So yes, you extubate them, they go back to the ward. Yes, certainly what you need to do is decide, say in a week's time, do I take them back to theater or do I scan them? One of these things have to happen because you have not put in a drain. It's, as you've seen, such huge collection, there will be such a lot of dead space in there. Yes, you made a good incision, you've opened up all the septations and all that. But so that you have to do, either take them back to theater for an EUA or scan them. And there's no right or wrong answers.
Okay. And the case that we did recently, we put in an NG and
Yeah, I mean, that was a bit odd. I mean, as I also saw them post-op, and so that was a bit odd. But generally, they improve. Generally, if they were swallowing okay before, they should be swallowing okay after. Um, yeah, I mean, that was a bit of an odd kid, or I can't explain why that kid struggled.
Yeah. Last two questions. Do the stents you insert for choanal atresia cause any septal complications?
They shouldn't, is the answer, because that's where your columellar strut that you saw, that little piece of bridge piece that you saw, was quite key, because that's what keeps those two endotracheal tubes separate. So that bridge piece is the key, which prevents septal. Yes, I'm just thinking back, occasionally, at the back, that nylon piece is rubbing a little bit at the back end of the septum. So yeah, there might be a little bit of injury at the back end of the septum, but that's completely almost irrelevant.
Okay. And last question, at what age do you operate on unilateral choanal atresia?
Any age when I diagnose it. So yeah, I mean, I don't have any hesitation. I don't have any issues. Your bilaterals, you operate at birth. So with unilaterals, there's no urgency. So, but yes, if I pick them, I think the recent one that you also were involved in, Reshma, I think that kid I picked up at maybe 1.5, 2 years of age. So yeah, I would make a diagnosis, scan them, operate. I won't have any issues. It's a discussion with the parents. So yeah, I don't have any hesitations operating at any age.